part of immunological diseases. Okay, we'll start with autoimmune diseases. What is autoimmunity? Autoimmunity can be defined as the presence of immune responses against the self-tissue. And autoimmune diseases result from failure of immune tolerance, which is the process by which the immune system recognizes and accepts self-tissue. During fetal development, the body will know itself, will know its antigens, and it will be able to identify the foreign antigen tolerance. If this process fails, the body cannot recognize itself, and this results in autoimmunity. Classification of hypersensitivity. You have type 1 hypersensitivity, which is an IgE-mediated mast cell degranulation, such as allergic diseases, and it does not result in autoimmune disease. Type 2 hypersensitivity reaction. It is an antibody-mediated, and it results from binding of the cytotoxic IgG or IgM antibodies to the antigen on the cell surface and causes cell killing. Examples are ABO blood transfusion and hyperacute transplant rejection. The example of autoimmune disease here is autoimmune hemolytic anemia, ITP, which is immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura, and Goodpasture's disease. Type 3 hypersensitivity to. Here, the IgG or IgM binds to soluble antigen to form an immune complex. This immune complex will result in classical complement pathway activation. Examples are serum sickness and farmer's lung, and it results in SLE, which is systemic lupus erythematosus, and cryoglobulinemia as examples of autoimmune diseases. Type 4 which is the delayed type, it results from activated T cells and phagocytes. Examples include acute cellular transplant rejection and nickel hypersensitivity. And as examples of autoimmunity, it results in type 1 diabetes and Hashimoto's thyroiditis. Hashimoto's thyroiditis is an inflammation of the thyroid. It results in transient hyperthyroidism, followed by a phase of euthyroidism, followed by hypothyroidism. How will we investigate autoimmunity? The first thing is by autoantibodies. Many autoantibodies have been identified and are used in the diagnosis and monitoring of autoimmune diseases. They can be quantified either by titer, which is the maximum dilution in the serum, or by the concentration in the standardized units using the ELISA technique, or by qualitative tests for anti-nuclear antibodies in which the pattern of nuclear staining is recorded. This is an example of the investigations. This is the ELISA and the quantitative detection, and this is the qualitative detection of detecting the type of anti-nuclear antibody. I think you got this more in the Department of Immunology. The second investigation is by detecting the complement. Measurement of the complement components can be useful in the evaluation of immune complex mediated diseases, which we said type 3. The classical complement pathway activation leads to decrease in the circulating C4 levels, and this is often also associated with decreased C3 levels. And serial measurements of these is useful as a surrogate measure of the disease activity in conditions such as SLE. يعني احنا اذا نقيس نسبة السي 3 والسي 4 راح نعرف انه ايش قد مدى المرض يكون فعال، لانه راح تعكس لنا صورة الاكتيفيشن اوف ذا كلاسيكال كومبلمنت.
دكتور أوس العفو.
تفضل.
دكتور هي المفروض تزداد يعني
لا لان هذا راح يصير ديجريديشن، راح يصير كونسومشن للكومبلمنت باثوي، فراح يقلل الكومبلمنت.
تمام دكتور.
Cryoglobulins, these are antibodies directed against other immunoglobulins. يعني antibody على الantibody. These form immune complexes and they precipitate in the cold temperature. They can lead to type 3 hypersensitivity reaction لأن هو immune complex حالة immune complex العادي with typical clinical manifestation including purpuric rash, often in the lower extremities and associated with arthralgia and peripheral neuropathy. Testing of cryoglobulins requires the transport of the serum specimen to the lab at 37 degrees. ليش؟ لأنه if we transferred it at a lower temperature, it will precipitate and we cannot detect it further in the serum. Cryoglobulins should not be confused with cold agglutinins, which are autoantibodies specifically directed against the II antigens of the surface of the red cells, which results in intravascular hemolysis. يعني عادة يصير mistake بيناتهم. أكثر شيء يسموه cryoglobulins أو يسموه cold agglutinins. The cryoglobulins يسوي لنا type 3 hypersensitivity result in this purpuric rash, arthralgia, and peripheral neuropathy, and the cold agglutinins راح يسوي لنا hemolytic anemia in the cold. Allergy, they compromise a range of disorders from mild to life-threatening and affecting many organs. Atopy is the tendency to produce an exaggerated IgE immune responses to other harmless environmental substances, while an allergic disease can be defined as the clinical manifestation of this inappropriate IgE immune response. Pathophysiology of allergy. The initial exposure to a normally harmless exogenous substances known as an allergen triggers the production of specific IgE antibodies by activated B cell. راح يجينا allergen من الانفايرمنت اللي هو المفروض يكون harmless. These B cells will produce IgE against this. These IgE will bind to high affinity receptors on the mast cells. On re-exposure to the allergens, these allergens will bind and cross-link the membrane-bound IgE. ولكونه يعني one of the emergency presenting features of واكو مشكله بالصوت شيء؟
لا دكتور صوتك واضح.
يا اما طبيعي دكتور، يا اما
تمام.
طبيعي.
تمام. لانه الموضوع مهم بصف ثالث، وهم بصف رابع، وهم بصف سادس، فخليته بالبدايه وركزنا عليه اكثر شيء. This is an illustration. This is the allergen, and this is the group of the B and T cells. With the help of T cell, the B cell will recognize the antibody and will result in the production of IgE antibodies, and this will form a complex by binding to the receptor over the mast cell. This complex اللي هو يتكون من ال IgE and its receptor حيكون attached، يبقى attached للماست cell. هذا بإنزيماتيك activity. Once there is re-exposure راح يجي الانتيجين يدخل مرة ثانية للبودي، ما راح يحتاج برودكشن، أصلا هو الانتي بودي مالته موجود. اللي راح يصير راح يرتبط مباشرة بالكومبلكس هذا، and it will result in series of enzymatic activation resulting in release of these vasoactive substances اللي تشمل لنا الهستامين والتريبتيز and other vasoactive peptides. Clinical manifestation of allergy include dermatological, urticaria, ectopic eczema, chronic allergic contact eczema and angioedema, respiratory, asthma and atopic rhinitis, ophthalmological, allergic conjunctivitis. GIT include food allergy, and others include anaphylaxis, drug allergy, and allergy to insect venom. How will we investigate a patient with allergy? This includes skin prick tests, specific IgE test against a suspected allergy. يعني skin test we expose the body by pricking it with multiple different allergens, and we know which is the type that's producing the identify the IgE against what we suspect, or supervised exposure to allergen, semi-allergen challenge. Mast cell tryptase is another type of investigation. It is useful in investigating a possible anaphylactic event, and ideally measurements should be made at the time of the reaction following appropriate resuscitation, and 3 hours and 24 hours later. The basis of the test is in fact that circulating level of the mast cell degranulation products rise dramatically to peak at 1 to 2 hours after the systemic allergic reaction, and tryptase is the most stable of these and easily measured in the serum. يعني احنا mast cell after being activated and release of these substances, multiple substances will be present in the serum. احنا ايش نحتاج؟ احنا نحتاج شيء يكون ستيبل، ما يصير ب degranulation بسرعه، عفوا يعني ما يصير ب degradation بسرعه. The most stable one هو التريبتيز. فاذا احنا قسنا التريبتيز فراح نقدر نعرف انه صار عندنا ماست سيل اكتيفيشن، وهذا السيستميك رياكشن اللي صار it was activation. Serum total IgE, peripheral blood eosinophils. Eosinophilia is common in atopic individual but lacks specificity. ليش؟ لأنه عندنا other types of diseases that result in eosinophilia. If eosinophilia is more than 20%, or there is an absolute neutrophil count of over 1.5 في 10 أس 9 per liter, this should initiate a search for non-atopic cause, such as eosinophilic granulomatosis with polyangiitis, Strauss, or parasitic infection. يعني نشوف عندنا الكومبليت بلاد كاونت، نشوف البرسنتج مال النيوتروفيل اذا اكثر من 20%، او اذا حسبنا الابسوليوت كاونت by multiplying this percent, the percent of eosinophil count multiplied by the total number of white BC، راح نشوف الفراكشن اوف eosinophil ايش قد. يعني لنفترض انه اليوزينوفيل كانت 15%، بس الوايت بي سي كاونت مثلا هو 20,000، يعني 20 في 10 أس 9 بير لتر. اوكي، فاللي راح يصير انه if you count this you get a eosinophil count more than 1.5 by 10 to the 49, and this should initiate then search for Church-Strauss disease or parasitic infection. How will we manage? First, you should always inform the patient to avoid the allergen. You should focus on this. You should stress on this step, and you should always ask your patient in the follow-up visit that has avoided the allergy, because one of the failure of the measurements of the measures to treat allergy is by not avoiding the allergy. Antihistamines, these are useful in the management of allergy as they inhibit the effect of histamine on tissue H1 receptor. If we want to prevent the attack, يعني نسميها prophylaxis, we should use long-acting, non-sedating preparation. يغطي لنا فترة طويلة وما يسبب لنا sedation. حتى المريض يقدر يتعود عليها بسرعة وما تأذيه، ويقدر يكمل حياته بصورة طبيعية بدون أنه يتعرض للألرجي وبدون أن يتعرض للسايد effects of medication. Glucocorticoids, أما topical, which is preferred because of its less side effects, or sometimes we may need systemic. Sodium chromoglycate, this stabilizes the mast cell membrane. It is effective as a prophylaxis asthma and allergic rhinitis, but has no role in the management of acute attacks. It is poorly absorbed and therefore ineffective in the management of food allergies. Antigen-specific immunotherapy, this involves sequential administration of increasing doses of allergen extract over a prolonged period of time. نعرض المريض إلى جرعة كل مرة تزداد حتى الجسم يتعود عليه. لازم تجرى بسبيشالايز سنتر، مو بأي مكان. وين راح تفيدنا؟ راح تفيدنا بالprevention of insect venom anaphylaxis and allergic rhinitis secondary to grass pollen. شافوها بالclinical studies انها تكون ineffective in the management of food hypersensitivity، ولكن لا يزال الدراسة مستمرة بهذا الفيلد. Omalizumab, it is a monoclonal antibody directed against IgE It inhibits the binding of IgE to mast cell and basophils. شو وقت الإنديكيشن؟ Treatment of refractory chronic spontaneous urticaria and for severe persistent allergic asthma that has failed to respond to standard therapy. هذا مهم الانديكيشن مال اماليزوماب. Adrenaline or epinephrine given by injection in the form of preloaded self-injection. This can be life-saving in acute management of anaphylaxis وتكلمنا عليه المحاضرة السابقة. إلى هنا أكو سؤال؟
دكتور يعني قصدك بالالرجيا انه الايزينوفيل ما تصعد فوق ال 1500 لو شلون؟
اي عادة ما تصعد فوق ال 1500. إذا شفناها فوق ال 1500 لازم نتأكد أنه ماكو ديزيز آخر مثل الشيركس تراوك باراسيتيك انفكشن، لأنه يعني صعودها لهيك مستوى يخلي بالنا دايجنوزز آخر. بس مجرد تشوف أنه عندك هاي ايزينوفيل كاونت more than 20% as يعني relative value or more than 1.5 في 10⁻⁹ هذا لازم تدور على دايجنوسيس اخر، ما يصير تعتبر هذا الرقم ناتج من الالرجي.
تمام دكتور.
Come to angioedema. What is the definition of angioedema? This is an episodic, localized, non-pitting swelling of submucous or subcutaneous tissue. It may be a manifestation of allergy or non-allergic degranulation of mast cell in response to drugs or toxins. And the main cause is the mast cell degranulation with the release of antihistamine or other vasoactive mediators. عندنا type نسميه hereditary angioedema. The cause here is C1 in complement 1 inhibitor deficiency, which causes increased local release of bradykinin. Angiotensin converting enzyme inhibitor induced angioedema also occurs as a result of increased bradykinin due to the inhibition of its breakdown. ليش؟ لأن angiotensin converting enzyme will act also on bradykinin. So if you inhibit this enzyme, it will result of accumulating bradykinin, and in certain individuals this will result in angioedema. Angioedema is characterized by soft tissue swelling that most frequently affects the face. مثل هذا المريض، شوفوا هذا شلون كان وشلون صار بالangioedema. But can also affect the extremities and genitalia. Involvement of the larynx or tongue may cause life-threatening respiratory tract obstruction. And edema of the intestinal mucosa may cause abdominal pain and distension. For certain individuals, even secondary to will not have cough as a side effect, but will have abdominal pain and diarrhea. Abdominal tension. This is all due to intestinal angioedema. And here the treatment will be by stopping the ACE inhibitor and changing it to other medication if required. Angioedema, allergic reaction to specific trigger, idiopathic, hereditary, and ACE inhibitor associated. هذا الجدول الطويل يقارن لنا different types، راح نجي ونشوف. In allergic reaction, the pathogenesis is IgE. In idiopathic type, this is non-IgE mediated degranulation. In hereditary angioedema, it is C1 inhibitor deficiency, bradykinin. ACE inhibition of breakdown of bradykinin resulting in its accumulation. The key mediator in the first two types will be histamine, while in the second two types will be bradykinins. The first two types are common. The hereditary angioedema is rare, and it is autosomal dominant disorder. The ACE inhibitor-associated angioedema is 0.12% of the patient treated with ACE inhibitor. Clinical features of type 1 associated with urticaria, history of other allergies is common, and follows the exposure to specific allergen in food, animal, dander, or insect venom. An idiopathic angioedema usually associated with urticaria, but may be triggered by physical stimuli such as heat or exercise. The hereditary is not urticaria. هذه مهمة الحكاية. Or other features of allergy, and does not cause anaphylaxis, but may cause life-threatening respiratory tract obstruction by obstructing the larynx. This can cause severe abdominal pain also. ACE inhibitor associated angioedema is not associated with urticaria and does not cause anaphylaxis, and usually affects the head and neck and may cause life-threatening respiratory tract obstruction, and can occur years after the start of treatment. يعني إذا شفتوا مريض angioedema ACE inhibitor for a long term، بادي قبل مثلا سنة أو سنتين أو حتى أكثر صار عنده angioedema. So you should not exclude ACE inhibitor as a cause of this angioedema. Change ACE inhibitor by all means to other medication if required. نحول إلى another antihypertensive or another anti-failure agent مثلا إذا احنا نحتاج ACE inhibitor، نحتاج benefit of ACE inhibitor. Investigations of the allergic type in specific tests or skin prick tests, of the idiopathic type by specific IgE tests and skin prick tests, resulting in negative results, and you should exclude hypothyroidism. The hereditary angioedema, you should measure complement C4, which is invariably low in the acute attacks. لأن قلنا راح يصير عندنا consumption, and you should measure the C1 inhibitor levels. In the ACE inhibitor type, there are no specific investigation. Treatment of the allergic type is by allergen avoidance and antihistamines. In the idiopathic angioedema, antihistamines will be the mainstay of treatment and prophylaxis. In the hereditary angioedema, it will be unresponsive to antihistamine, but patient may benefit from anabolic steroids or C1 inhibitor concentrate or icatibant for acute attacks. In the ACE inhibitor associated types, you should discontinue the ACE inhibitor. ARBs should be avoided if possible. unless there is strong indication. يعني إذا إحنا عندنا ACE inhibitor, the common practice is to change ACE inhibitor to ARABs اللي هو angiotensin receptor blocking receptor. But طبعا this practice in the management of cough associated of ACE inhibitor, association of ACE inhibitor or side effect of ACE inhibitor. But if you have angioedema resulting from ACE inhibitor, you should at your best avoid ARBs, because some ARBs, some ARBS will also result in angioedema. So you should change your plan, you should change your medication, your antihypertensive or your anti-failure measure to avoid then وبالهارت فيلير. بالهايبرتنشن ممكن نلقي another class، مثلا نلقي كالسيوم channel blockers. بالهارت فيلير المشكله انه it is very useful. If we tried our best مثلا نبدله نخلي مكانه hydralazine and nitroglycerin combination instead of ACE inhibitor or ARBS. Associated drug reactions include specific drug allergies, non-steroidal and idiopathic angioedema, opiates and radiocontrast media, and in ACE inhibitors مثل ما قلنا هم ACE inhibitors and ARBS. Short note about the C1 inhibitor deficiency, acquired C1 inhibitor deficiency. This is a rare disorder and is clinically indistinguishable from the angioedema. It presents in late adulthood. It is associated with autoimmune for proliferative disease. Most are due to antibody inhibitor caused by antibody C1. Treatment of the underlying induction of angioedema. As with hereditary angioedema, OC4 is seen during the acute episodes. اكو سؤال شباب؟
دكتور عاوز عفوا.
اي تفضل.
دكتور ليش بالاجاباتك انجيوديما وي شود اكسكلود الهايبوثايروديزم يعني؟
تعطيك فكره تشبه الميكزيديما مال الهايبوثايروديزم.
تمام دكتور.
Transplant rejection. The solid organs transplantation will inevitably stimulate an aggressive immune response by the recipient unless the transplant is between monozygotic twins. From the body, stimulate antibody formation, just as any antigen entering the body. The type of and severity of the rejection is determined by the genetic disparity between the donor and recipient and the immune status of the host. The most important genetic determinant is the difference between donor and recipient HLA proteins. The donor HLA antigens are almost invariably recognized as foreign by the recipient immune system unless the active attempt has been made to minimize the incompatibility. مثل ما قلنا هو انتيجين دخل للبودي والبودي ما متعود عليه، ماكو توليرانس لهذا الانتيجين فراح يصير انتي بودي. زين. How can we minimize this? By trying to make as much as possible ان ال HLA انتيجينز تكون متقاربة. ناخذ من شخص قريب من عنده، إذا اكو مونوزايغوتيك توينز كان بها، ماكو مونوزايغوتيك توينز من أخوته، ماكو من أخوته من أهله، وهكذا. إلى ونسوي فحص مال المطابقة اللي سامعين به. أكثر واحد مطابق بال HLA هو the most suitable for donation لهذا الانديفيدوال. Hyperacute rejection is the first type of transplant rejection. It results in rapid and irreversible destruction of the graft. It is mediated by existing recipient antibodies against the donor HLA antigens due to previous exposure through transplantation, blood transfusion, or pregnancy. البدي أصلا موجود ب antibodies. فما يحتاج formation of antibody in order to destruction. Antibodies are already present. Once you transplant, the antibody will attack the tissue and result in the failure of. It is very rarely seen in clinical practice. ليش؟ لأنه احنا نسوي ال HLA antibodies ونشوف نسوي anti HLA antibodies بالrecipient, and we do pre-transplant cross-matching to ensure that the prior identification of the recipient donor incompatibility. Acute cellular rejection, it is the most common form of the graft rejection. It is mediated by active ulceration in function. If this allowed to progress, it may cause fever, pain, and tenderness over the graft, and it is usually amenable to increased immunosuppressive therapy. The acute vascular rejection, it is mediated by antibody formed de novo after transplantation, newly formed. It is more curtailed than hyperacute response because of the use of intercurrent immunosuppression. It is associated with reduced graft survival. Aggressive immunosuppressive therapy is indicated, and physical removal of the antibody may be needed through plasmapheresis, in certain severe cases. Immunosuppression to lower the antibodies, and if the antibodies concentration are very high, we want to remove these antibodies from the circulation by a process called plasmapheresis. We attach the patient to a certain machine, and this machine will filters the antibody in the plasma, نسميها plasmapheresis. The chronic allograft failure or chronic rejection, it is a major cause of graft loss. It is associated with the proliferation of transplant, vascular smooth muscle, and interstitial fibrosis and scarring. Here the pathogenesis is poorly understood, but there are certain contributing factors, including the immunological damage caused by subacute rejection, hypertension, hyperlipidemia, and chronic drug toxicity. يعني هو مو only immune response مثل ما the other three preceding types. هذا multiple factors. واللي راح يصير عندنا smooth muscle proliferation، ويصير عندنا interstitial fibrosis، ويصير عندنا scarring، وهذه as consequences of these راح يفشل الجرافت. وطبعا يكون باللونج تيرم. هذا جدول ايضا يقارن لنا ال different types. The time of hyperacute هو minutes to hours, and it is due to cross مثل preformed antibodies, and it has no treatment. Unfortunately, there will be irreversible graft loss. مجرد ان صار عندنا hyperacute rejection انتهى الموضوع، ما عاد اي تريتمنت. الجرافتنج فشل. acute cellular necrosis يكون 5 to 30 days، والاكيوت vascular rejection ايضا 5 to 30 days. تني ان الاكيوت within 30 days. اوكي، كلمه acute هنا بالترانسبلانت within 30 days. بالسيلولار ريجكشن راح يكون سيلولار انفلتريشن، بالفاسكولار ريجكشن راح يكون فاسكولايتس. both acute, the treatment is increasing immunosuppression. Okay, acute rejection increase immunosuppression. The chronic more than 30 days يكون عندنا fibrosis وscarring مثل ما قلنا عندنا multiple mechanism, immune and non-immune. We should control the precipitating factors. Increasing immunosuppression will have no result here. يعني عندنا drug toxicity, we should minimize drug toxicity. عندنا hypertension, we should control hypertension. عندك hyperlipidemia, control hyperlipidemia, etc. Okay, any questions? Okay, إذا ما عندكم سؤال.
شكرا دكتور.
اوكي، بس قبل ما تروحون